Welcome to the NWA-ETC Project ECHO. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
Well, I don't think Dr. Danreddy needs much of an introduction. I think most of you know her. She's part of our expert panel here and is assistant director of our Madison Clinic and director of the Infectious Disease Clinic. And I asked her to give an update on conception options for positive patients.
Well, thank you for inviting me. So this is going to be sort of an overview talk to think about options for patients, and also just some basics about primary care and conception issues to go over with patients, and keep that in mind because we're always get busy with the HIV management and we don't really think about stepping back and talking about reproductive issues with our patients. So wanted to just highlight the importance of reproductive issues as part of healthcare and healthcare maintenance, and then talk about safer pregnancy, achieving a safer pregnancy in women that are HIV positive, as well as some reproductive options for those who do have issues with fertility, and as well as who are in serodiscordant couples and what options they may have. Reproductive issues are really important in primary care. A significant number of the infections that occur yearly are in women, and we know that is rising, but there's over 10,000 new infections in women a year, and the majority of those women are in the reproductive age. And we know sort of across the US, not just in HIV-infected women, that 50% of pregnancies are unintended, and 19% of those are unwanted. And that's much higher even in women that are HIV positive. And so 80% of pregnancies in HIV-infected adolescent women are actually unintended. So that's a pretty high number. And one of the caveats is here that sometimes people will report that it's unintended even if it is intended. So that's one of the issues that we get with. But still, regardless, it's a very high number of unintended pregnancies. And when we look at data that was just published this year at unplanned pregnancies in HIV, and so this shows the dark black is unplanned and the gray is planned pregnancies. And as you can see, the first column there is for your first pregnancy, that the majority of those are unplanned pregnancies. And even in the second, third, fourth pregnancies, there's still a lot of unplanned pregnancies, meaning that first episode we should really be highlighting the importance of reproductive health and contraception, and that's not necessarily happening throughout the care of a woman with HIV. So 48% of women who were surveyed in this study reported that, who were pregnant or considering pregnancy reported that they were never asked by their healthcare provider about their desire for pregnancy. And so, like I said, a lot of times we're busy dealing with other issues, substance abuse, adherence issues, getting people on medications and treating OIs, that we forget about some of the basic things that people do, like have sex and get pregnant. So we need to really have that on our radar. And also in this study, they found that 57% of patients who were pregnant or considering pregnancy had not discussed appropriate HIV treatment options with their provider before becoming pregnant. So they didn't say, I'm thinking about getting pregnant, do I need to adjust my therapy? And then conversely, it was never brought up by their provider either. So this is really important to highlight. We do need to be thinking about that in all people of reproductive age that we care for. So one of the first things that we talk about and then we try to emphasize is disclosure to the partner. So if they're in a relationship and thinking about having a child, we want to make sure that that partner knows that they're positive. And Kari, who's sitting here, probably knows that that's not always the case. We make that assumption, but that's not always the case. And sometimes partner may not even know that the patient is trying to conceive. So that's really important to talk about disclosure, and even inviting that partner of the patient to the discussion, if the patient is amenable to that, to talk about reproductive issues. Contraception, so we divide it into people who are of reproductive age who want a baby or who don't want a baby. And so if you determine that they don't want a baby or they don't want a baby just yet, we really need to be talking about contraceptive use. And it really surprises me, and I know Brian attends in our clinic too, how many times people forget about this basic issue when dealing with women in our clinic, to talk about condom use or not condom use, but contraception. We are really focused on decreasing transmission, but we're not so focused necessarily on the other piece, and of hormonal contraception or IUDs. And so condom use, yes, that's helpful for reducing transmission, but then we're also think about hormonal contraception. And I know Dave Hatchie's on, but there's a lot of issues with drug interactions with antiretrovirals. So really knowing those drug interactions and making sure that those levels of hormones are not too low and that you're still having effective results from your oral contraceptives. Depo-Provera is another option for patients who are maybe not be able to take a pill every day or most days. There were some studies, as you probably heard, that there was this concern for increased risk of HIV transmission in women who were on Depo-Provera, although there have been some subsequent analyses that show that that's not probably substantiated. However, that is still a concern that people have, and that's being further explored through studies. IUD, I think our area is actually, our gynecologists are really big on using IUDs in our patient population, and I think they've gained some more and more acceptance. There's no increased risk of infections in women who are HIV positive who get an IUD, and no increased risk of other complications. So it is really, has been shown to be an effective, safe method of contraception in women who are HIV positive. Of course, just a general discussion about safe sex as part of healthcare maintenance is always really important. And then talking about pregnancy. Are you thinking about getting pregnant? Because maybe we would address your and alter your antiretroviral regimen if you are thinking about getting pregnant. A lot of women come and say, I want to be on a 1 pill once a day. They've heard about Atripla. They want to be on Atripla or Stribild, and they don't. That weighs more heavily than thinking about pregnancy. But things change, and people change their minds about getting pregnant, and we want to have that as an ongoing discussion to determine if you need to come up with a different antiretroviral regimen. And we'll talk about which ones are acceptable and not. So of course, just like in any population of women, not just HIV infected, we want to promote a safer pregnancy. So if you have patients that are thinking about becoming pregnant, you want to counsel about avoiding alcohol, illicit drugs, and tobacco use. We know that the substance abuse issues are more prevalent in our patient population, so really being mindful of that. Achieving virologic suppression, so that is key, and optimally before they get pregnant. Now that everybody should be on antiretroviral therapy, that people are hopefully suppressed before they even conceive. And then avoiding teratogenic medications, and we'll talk about some of those ART regimens in particular. And of course, starting a prenatal vitamin on any woman who's thinking about getting pregnant, because those neural tube defects happen very early. And if you start after you already know that you're pregnant, oftentimes that folic acid benefit isn't really there. You really need to have it on board when they're at the time of conception. ART in pregnancy, and these are actually, these next couple of slides are actually from Brian, who reviewed this after he went to Croix and looked at the data from the French cohort and concern for teratogenic effects of efavirenz. So everybody's concerned about efavirenz, and that's because there had been prior studies looking at animal models where there was increased risk of neural tube defects and also birth defects that were associated with efavirenz during first trimester exposure. Also, some concerns about AZT. And so there was actually a large review of the French perinatal cohort that was multiple centers, many thousands of pregnancies and babies looked at. And what they've basically found is that efavirenz was associated with birth defects, although not very many, that occurred at the time with exposure at the time of conception. And really after that, there was really not any increased risk of further defects or any other or increased risk of exposure. And so based on this data, that really led to some changes in the guidelines about how to incorporate efavirenz. So essentially, if a patient is considering getting pregnant, then we try to avoid efavirenz because of those early potential, and primarily neural tube defects that occur with efavirenz exposure to efavirenz at the time of conception in those early first few weeks. However, as you can see later in the slide at the bottom, most women find out that they're pregnant after the risk of efavirenz has already been there. And so we don't actually recommend a change in antiretroviral regimen if they're on efavirenz after 8 weeks of gestation. If they're already, they're getting started on antiretroviral therapy during pregnancy, the preferred regimens that you see are those nuke backbones are pretty common, what we use right now anyway, even in non-pregnant women. So tenofovir, emtricitabine, or lamivudine. abacavir and making sure that they're HLA-B5701 negative. And zidovudine, although less and less in practice are using zidovudine just because of toxicity issues and the BID dosing that comes with that. In terms of an anchor medication, the drugs that are really preferred are boosted atazanavir or boosted lopinavir or efavirenz as the NNRTI anchor. There are alternative anchor medications which include darunavir, sequinavir, nevirapine, and raltegravir. And as we know, a lot of the pregnant patients that have been presented here have actually been on raltegravir-based regimens, even though it's an alternative, just because of increased tolerability in these regimens as opposed to PIs, which tend to have a lot of gastrointestinal side effects. And as we all know, pregnant women have a lot of GI side effects. And so even though it's an alternative regimen in the current guidelines, it tends to be patient preferred in many circumstances. There are a lot of regimens that we use commonly in non-pregnant women as first line that you can see are not here. So rilpivirine, elvitegravir, or incorporated in Stravil are not here just because there's not much data currently with those drugs in pregnancy. But we'll probably have data forthcoming in the next few years that may change this further. So fertility issues and in dealing with serodiscordant couples and seroconcordant couples. So 59 to 80% of HIV-infected women report a desire to have children. And so we really want to focus on optimizing maternal health as well as preventing transmission to the fetus and preventing transmission to the partner. So of course, the usual OB issues that we deal with, as well as this prevention of transmission. In a seroconcordant couple, so they're both HIV positive, basically we want to achieve maximum virologic suppression in both individuals, ideally prior to conception. Also, prior to attempting to get pregnant, screening and treatment of any STIs, so making sure both individuals are treated for any STIs that they may have. And the guidelines actually say consider referral to an OB provider knowledgeable in the care of HIV-infected women. And so I put Jane Hitty is our local person who is our preferred HIV OB provider. But not always will there be that kind of person, and so you have to seek out who may be more comfortable in dealing with these issues. Many OBs in our area, because Brian and I do satellite clinics and outside of the Seattle area, and we found that actually a fair number of OBs are comfortable taking care of these patients, and sometimes they'll just ask for a one-time consult with Dr. Hitty, but otherwise are able to care for these patients. In terms of serodiscordant couples, this is where it gets a little bit more tricky. So when the woman is HIV positive, it's actually a little bit simpler because the safest option is artificial insemination. And that could include self-insemination, so the quote-unquote turkey baster method of using the HIV uninfected male semen and inseminating herself, and maximally to achieve maximal effect of getting pregnant during the periovulatory period. Another alternative that is put out there in the guidelines is pre-exposure prophylaxis. So basically optimally timing unprotected sex, if you're not going to go with the safest option, to the periovulatory period, otherwise having protected intercourse, and then using pre-exposure prophylaxis prior to that unprotected intercourse so that you can decrease the risk of transmission to the male. However, in the HIV negative woman with a positive male partner, it is quite tricky. And the safest option and preferred option that's put in the guidelines is donor sperm, which, as many of you know, is not considered a real option for many of our patients because they're in a relationship with a partner and they want to have a child with that partner rather than using donor sperm. Even though that's the safest option and preferred option, most look to other options because they want to have a child with that male partner who's positive. So the other options that are outlined in the guidelines are sperm washing with intrauterine insemination or IVF. However, we don't really have facilities that do sperm washing in our area. And I'm sure that that's similar to where you're working as well. And it's a very costly technique. And so what they do is essentially wash, they take the sperm sample, wash it, check it for HIV, and then that is used to inseminate. That technique is only done in a few places. It's more widely available in Europe than it is here. And then, of course, we know that IVF is quite costly and most insurance doesn't cover IVF. So it's not a realistic option for many of our patients that we care for. One other thing that's recommended for all patients, all HIV-positive males who have a negative female partner, is actually doing a semen analysis. And this is not something that we think about often. And it's generally not covered by insurance, and it can be costly. I think our OBs say it's about $200 or so, and that's basically to make sure that the semen is viable. If it's not viable, then why have unnecessary, unprotected sex and risk transmission to the female partner? So if the semen is not viable, then they would recommend stop and using a donor sperm. So that's kind of just an initial starting point with HIV-infected males. And I will tell you that it's generally not done in practice because it is an out-of-pocket expense, and so a lot of men are not willing to pay that. However, if they do have the financial means, it's something to pursue. Lastly, pre-exposure prophylaxis. That is something that's gotten a lot more acceptance in the last iteration of the guidelines than previously, when the previous iteration really didn't have a lot to say. It said maybe an option, but more data needs to be forthcoming. But we know from large studies like HPTN 052, which was the serodiscordant couple trial that was multinational, that showed there was only one linked transmission in individuals where the positive patient was on antiretroviral therapy. We know that that is beneficial to have that patient be undetectable, but we don't know what the benefit of PrEP is if someone is undetectable. So if that male partner is undetectable, there's no studies on any additional benefit of using PrEP in that setting. However, we don't know. And we don't know if it's even if they're on effective antiretroviral therapy and suppressed, we can't say it's zero necessarily, that there's a risk of transmission. So PrEP is still being used. The studies that looked at PrEP in serodiscordant couples, so the large Partners PrEP study that was done with Jared Baton and Connie Kellum as the principal investigators from here, that basically when the woman got pregnant, they were taken off the study. So we don't have a lot of data in HIV-negative women who got PrEP or Truvada, but we have a lot of data in HIV-positive women on Truvada that it's relatively safe. So that's what's compelled this guideline change to include pre-exposure prophylaxis as an option, given that the other options are not that palatable or affordable or available. So in summary, I think the main points here are discussion of family planning is really important for all patients of childbearing age, and initially to just know, okay, you're in childbearing age, do you want to have a baby or you don't want to have a baby? And figuring that out, because then you can address contraception and other issues and have that conversation, because people change their minds. They could meet a partner and change their mind about having a kid. So it should be part of routine health maintenance. And then optimizing the woman's health, not just through achieving virologic suppression, but also in terms of substance abuse issues and other comorbidities that you'd want to optimize. And then consider a pregnancy plan when you are prescribing ART. So if someone is of childbearing age and they may have a kid, you will probably want to avoid efavirenz in that setting. And then considering pre-exposure prophylaxis for the HIV-negative partner. I'd be happy to take any questions from the